Aloha, my name is Leanne Briggs, and on behalf of the Caregiver Foundation, I'd like to welcome you to our monthly Caregiver Support Group. And now I'd like to introduce Executive Director Gary Powell, who will introduce our speaker topic for today.
Welcome, everybody. We're so honored to have Dr. Suzuka with us today. And Dr. Suzuka is a geriatric medicine specialist with offices in the Queen's Healthcare System centers in Haleiwa and Mililani. And he's been in medicine for over 38 years. Graduated from the University of Hawaii School of Medicine in 1983 and has served as assistant clinical professor of medicine at the John A. Burns School of Medicine since 1992. Dr. Suzuka has received numerous awards and commendations and is listed as one of the Castle Connolly regional top doctors, that's Honolulu Magazine, in 2015, 16, 17, 18, 19, 20. Dr. Suzuka currently serves as a member of the state of Hawaii's COVID response team and COVID vaccine medical advisory working group. That's quite a mouthful. But we are really glad that you can join us, and thank you very much. And I'll turn it over to you, Dr. Suzuka.
Okay, so one disclaimer is that I'm not speaking on behalf of any of those groups. I'm speaking on behalf of myself. So just want to make that disclaimer. Okay, and I'm going to go ahead and share my screen and start the presentation. Oh, I'm going to try to share my screen. Let's see, somebody will need to help share my screen.
That would be Gary. Just a minute.
Okay.
Yeah, Gary, I believe you will go ahead and might need to give Dr. Suzuka co-host privileges.
Here are the steps. Step 1, answer the call. Step 2,
Sorry about that, a little technical issue here. Josh is figuring that out. While he's doing that, Dr. Suzuka, let me ask you just a general question. How have you personally found your reaction to COVID in the medical profession? Impacted you?
Personally, or in medicine, it's changed things because we, before COVID, we hardly did anything by telehealth. Now we do some telehealth. We still see many of our patients in person, but we've had to set up triage protocols to make sure that people are safe. We've had to set up office protocols to make sure that people are safe. But we didn't do any telehealth prior to COVID, and now we do. And as I mentioned earlier, it's very nice not to have to go to meetings in person and to do all the meetings by Zoom. So that part is very, very nice. Oh, there we go. I guess I can share my screen. Okay. So, can everybody see the screen okay?
Yes.
Okay, we'll get rolling. Yeah. There we go. Okay, so this was the World Health Organization announcement on January 5th about the pneumonia of unknown cause from China. And I highlighted a little section on the bottom saying that there was no evidence of significant human-to-human transition. So we know how that has changed. That is no longer true. We know that it is very transmissible. And then here's some of the highlights from some of the journals. Lancet was one of the first journals on January 24th, and then New England Journal and JAMA came out with their articles on February 20th. So just a little less than a year ago were the articles that came out about COVID. I'm gonna go take a little history timeline back. Probably most people are aware of December 31st, 2019. That was the first public health warning from China. They announced that there were 27 cases of viral pneumonia. 7 people were seriously ill. 66% of the cases were tied to the Huanan seafood wholesale market. What some people are not aware of is that actually it goes back before that. And the World Health Organization team just went into China to investigate further. And they also are finding that COVID probably existed even earlier than December 1st. So the first person, the so-called patient zero that was listed in the Lancet article that I just showed you, was reported on December 1st. They probably had it as early as November 17th. Now that person was 55 years old and had no contact with the Hunan seafood market. And in addition, there was a study later on from September 2019 to March 2020. It was actually a different study. It was a study for lung cancer screening in Italy. But when they looked at the blood samples from the participants, they found that 14.2% of the patients in that lung cancer study already had antibodies, IgG or IgM, to SARS-CoV-2. So apparently it was in existence in Italy even in September of 2019. Now, we don't know where else it's been in existence. There were some reports from sewage water in Brazil that had COVID as in November of 2019, but it's gonna probably turn out that it's not all just originated from China. China has been trying to get the World Health Organization to say that. World Health Organization will not say that yet, but there is evidence that it was in other parts of the world prior to December 2019. I already showed you the bulletin from the World Health Organization from January 5th, saying that there were 41 cases and no evidence of human-to-human transmission. And then on January 10th, the World Health Organization published their first guidance online. Okay, of interest, January 10th was also the date that China released the RNA sequence, it says DNA, but it's RNA sequence for COVID-19. And of a lot of interest, the NIH started the vaccine production or experiments on January 11th. So one day after the genetic sequence was released, Dr. Barney Graham of the NIH started the studies on COVID. January 19th was the first case of COVID in the United States, a 35-year-old male who came back from Wuhan to Seattle on January 15th, and he was noted to be sick on January 19th. January 30th, the World Health Organization declares a global emergency. 42 days later, President Trump declared a state of emergency in the United States. And of interest, almost just a little over 2 months after having the genetic sequence identified, the first person gets their shot of Moderna vaccine in Seattle. Jennifer Haller, who was a 43-year-old mother, was the first person to get the COVID shot, the Moderna vaccine. So this is remarkable. We've gone from finding a vaccine, a virus in December, to sequencing the genetic code in January 10th, to giving a vaccine on March 16th. So this is unprecedented in terms of scientific progress. What do we know now that we didn't know a year ago? Well, kids don't get as sick as adults. That's surprising because in most illnesses like the flu, kids are very susceptible. It affects the kids and the older people the most. But kids don't seem to get as sick as adults. They can still transmit it, but they don't land up in the ICU. Here's one that you might remember. The surface transmission is not as important as it was thought at the beginning. So people may remember that people were worried about what's going to happen to their mail, or they would clean off their milk cartons from when they came back from Costco or wherever they went shopping. Well, that's not as critical anymore. It's mainly the droplet and aerosol transmission. 10-day quarantine is enough to prevent spread. And we'll come back to that. I have another slide to show that. COVID is transmitted by airborne aerosol, not just droplets. You might remember that this was a big debate that they thought that it was mostly just droplets, but when you look at the data, it becomes clear that it's done by aerosol also. So that we can look at spread of COVID in apartment complexes in China, where it actually would spread 2 floors up. Now, normally droplets would settle down, so you would not see it transmitting upwards in an apartment complex. Cruise ships and the USS Theodore Roosevelt, the aircraft carrier, when you look at the transmission patterns, it becomes clear that it's aerosol, not just droplets. And choirs, so that's why choirs are so much of a concern, is when you sing in choir, you aerosolize the material. So there's been cases of 43 or 80 people in a church that have gotten COVID from someone singing, and that's a major concern. And that's why it's still recommended, even if you can meet as a church, that you should not have singing going on. So the difference, droplets are 5 to 10 microns. Droplet nuclei, which are the things that aerosolize, are less than 5 microns. Aerosols of less than 5 microns can actually travel 20 to 30 feet. So that's what makes it so so dangerous. So in a closed area without good ventilation, it's easy to infect other people. And that's why in many home settings, if someone is sick, everyone in the home has to wear a mask, even at home. COVID is spread by asymptomatic carriers. That's a big surprise. Generally, they didn't think that was true because with SARS and MERS, which are other coronaviruses, you don't have asymptomatic spreaders. But with COVID, up to 40% of the spread is by asymptomatic carriers. Here's another one that was a big controversy. Masks do work, and I'll show you some slides in a little while to show you how effective masks are. Face shields and masks work even better. So that was from a study in India where healthcare workers, not nurses or doctors, but community healthcare workers went to the community, and the protocol was that the family would come outside of the house and everyone was supposed to wear a mask, and the healthcare worker had a mask. And even with that, some of the healthcare workers got sick. And part of that is because some of the people in the household didn't have their mask on correctly. They might have it down below their nose, or they might have it loosely fitting. When the healthcare workers wore face shields and masks, then nobody got sick. So at Queens, we are required to have a face shield and mask whenever we see patients. And when I go out, if I go shopping or where there's going to be a crowd, I wear a face shield and a mask. Here's a big surprise. The biggest risk is your family and friends. So the risk of getting COVID from me in a healthcare setting is about 1%. People are safe going to their doctors. The biggest risk, and this is from the China studies, the biggest risk was from a family member. So when a family member had COVID, over 10% of the other people in the family would get COVID also. This is the slide on quarantine, the length of quarantine. So quarantino comes from the bubonic plague that occurred in Europe from 1343 to 1350. And the bubonic plague killed 1/3 of Europe's population. The initial quarantine was actually Trentino, 30 days in the Venetian-controlled port of Ragusa. They required the ships to quarantine for 30 days. And over the next century, it was increased to 40 days, therefore quarantine. And here's a slide from the CDC showing that the length of quarantine and the amount of spread. So if you look at and the little box at the right upper part, that's just an expansion of the 7 to 14 day period. So as you can see, as you head towards 10 days of quarantine, you significantly drop your transmission rate. And by 11 and 12 days, it's hardly existent at all. And the dark blue is if you have a negative test, the light blue is if you didn't have a test. So whether or not you have a test, 10 days is adequate to prevent spread of COVID. This was a very interesting study from, again, from the CDC. This was 2 hairstylists that had COVID in Missouri. In Missouri, everyone was required to wear masks. The 2 hairstylists spent 15 minutes with 139 clients. No one got infected. So, and as you can imagine, hairstylists are very close to their customers, and none of the 139 people got infected. Now, there were people that got infected. So hairstylist A gave it to hairstylist B because they were talking without their mask, not when seeing clients. And in fact, many of the healthcare facilities have noted that a lot of the COVID occurs not from patient to healthcare provider transmission, but in the lunchroom. So in many of the healthcare settings, like we have closed our lunchroom. Only one person can be in the lunchroom at a time. Now, the other people that got sick were the family members of hairstylist A. So there are 6 people in the home, all of whom got sick with COVID, but none of the clients had COVID, and both client and hairstylists were wearing masks. This is a slide from Stanford. This was at very early on in the, you might notice it was updated March 22nd. And at that time, you might remember that there was a hard time getting PPE. So the anesthesiologists at Stanford were looking at how else can we protect healthcare workers. So you can see that bacterial atrophius is a bacteria, and bacteriophage MS2 is a bacteriophage that's like a viral particle, and the bacteriophage is 2 microns. So what we're really looking at is like droplets versus small 2 micron particles. So surgical mask, as you can see, is the best. It blocks out 96% of the bacteria and 90% of the bacteriophage. But vacuum cleaner bags are 94 and 86% effective. So a HEPA filter vacuum cleaner bag actually filters out 3 micron particles. So I use a cloth mask with a pocket, and I put in a little cutout of a vacuum cleaner bag in that pocket. And then you can see as you go down the list, you have less efficacy among different materials. But surgical mask and vacuum cleaner bags are highly effective. I wouldn't recommend putting the vacuum cleaner bag over your head, but you could cut out a piece and put it in your mask. This was a study from JAMA Internal Medicine in August, and it looked at N95 masks, surgical masks, and procedure masks. So the pictures of the mask are on the right. So as you can see, an N95, which filters out 95% of particles 2.5 microns or less, really shuts out transmission of particles. The surgical mask does a pretty good job. You can see that it does almost as good as an N95. And the procedure mask is not as good. The procedure mask goes around the ear with the loops, and so you don't get as good a seal on the mask as you would with a surgical mask. So in the office, I wear a surgical mask and a face shield. This was a study from the CDC just recently, February 10th, and showing what they did is they had a mannequin. So on figure A on the left, you can see that was a mannequin that was the source that they ventilated particles from that mannequin. And you can see that with that mannequin has a procedure mask that has a gap on the side. And then they had masks showing double mask. So this is that double masking that a lot of people are talking about. So you can have a double mask with the procedure mask on the inside and a cloth mask over that. And the cloth mask is to give the procedure mask a better fit. Or you can have a procedure mask with a fitter that makes it fit closer to the cheek. And then when you look at that, so when you look at the amount of blockage, the most important thing, bottom line, is that if both the source and the receiver have mask, you cut down the transmission. If you either double mask or have a tight fitting mask, then that's the best. So if you can see that the double mask and the tight fitted knotted mask on the bottom, the dark blue on both, it reduces spread the most. And then in between, you have where the source has a mask and the receiver doesn't, or the source does not have a mask and the receiver does have a mask, then those are the other lines above that. And so as you can see, the most important thing is for 2 people to have a mask, but you could use a double mask, or you could use a well-fitted mask. You could put an insert inside. This study did not look at inserts like vacuum cleaner bag inserts, but you could have a double mask that would be better than a single mask by about 50% reduction in spread. Okay, going on with some of the other things we know, almost done. COVID-19 is a two-phase disease. So at the beginning, it's the viral infection, and then after that, it's the intense inflammation. So monoclonal antibodies and antibody cocktails work for outpatients while the viral infection is going on. The problem is that it's not real practical because right now it has to be given by IV infusion. So in other words, to stay out of the hospital, you have to go to the hospital to get the monoclonal antibodies, and that's not very practical. Another thing we've learned, ventilating patients on face down. So that has been a major benefit for the people that need ventilation. Remdesivir, you've probably heard of that. It's kind of going out of favor. President Trump used it. There was a study showing a 30% reduction in hospital days, but so far no reduction in mortality. And it would be interesting if you could use remdesivir early because it's an antiviral, but generally it's used when people are sick in the hospital. Dexamethasone, it's the only medication with definite benefit, and it's given to people that are sick enough that they're deteriorating or need to be on a ventilator. And then more recently, tocilizumab is a arthritis medicine. It's an interleukin-6 inhibitor, prevents infection, and there was a 35% reduction in mortality, but it was a very small study. I think it was only about 350 people, so it needs to be studied in a larger setting. We know that COVID affects almost every organ, lung, GI tract, heart, central nervous system, and that 80% of people who have COVID will have long-term symptoms. So that could be just like 3 months, or it could be indefinite. We don't know how long it is, but it can affect heart, it can affect brain, and it can affect lung long-term. So we do want to be careful about making sure that people don't get COVID. Here's the kind of final update type of thing is last week, the CDC came up with the fact that if you're vaccinated and you have been vaccinated after 2 weeks after your second dose, and it's within 3 months since you got your shot, and you got sick, or not sick, you got exposed to someone who had COVID, you don't have to be quarantined. Okay, so that's kind of big deal. Now, one problem is that this is a CDC guideline. It just got published last week. It does not free people yet from state quarantine. The state health department will have to make their decision on that. It does not get people out of travel quarantines. So those things will need to be determined by the states and other formal bodies. But the CDC, I'm sorry, has said that if you are exposed to someone with COVID, but you've been vaccinated and it's been more than 2 weeks and less than 3 months, you don't actually need to be quarantined. Okay, I have a whole bunch of other things, but I thought we could take time here to answer questions that people might have.
Yes, Dr. Suzuka, this is Leanne. Let's see, could somebody close the share screen feature? And I'd like to invite our audience. You can also ask questions through the chat feature. But I have a few questions lined up, and Gary will also jump in with questions. So about the vaccine, and we know that the Pfizer and Moderna vaccines are 94, 95% effective, but can you speak about what does that mean, that efficacy rate? And then also, what does it mean for the 5 or 6% that are not effective? You could explain that terminology for us.
Okay, so first you have to look at how the studies were set up. So the studies looked at prevention of symptomatic disease. So 95% effectiveness means that 95% of people who get the vaccine did not have symptomatic disease. They could have had virus, they could have shed virus, but that was not looked at. So first of all, it's only for symptomatic disease. It does not tell you that you will not get COVID or spread it to other people. It's that you will not have symptoms. For that 5%, that means that 5% of people who get the vaccine still could get symptoms. They could have fever, they could have trouble breathing, they could land up in the ICU. But 95% of people that get the vaccine will not have symptoms if they get exposed to COVID. Okay,
Oh,
second dose
yeah.
reactions. Should I address that?
Yes, please.
Okay, so in the studies, generally I tell people you will have a reaction. Okay, so I don't want people to think that they don't. It's worse when you aren't expecting something. It's better if you expect it and it's not as bad as you thought. Okay, so I tell people you will have a reaction. 80% of people in the studies had a sore arm or itching at the site. 60% of people felt fatigue. 40% had muscle aches. 30% had joint pains. 30% of people had headaches. 14% had fever. So generally, you will probably get something. Now, most of the side effects are pretty minor in that they last 1 to 3 days. And generally speaking, the only thing that would force us not to be able to work is the fever. So if I had fever from the shot, I would have to be out for 7 days. Okay, but none of our doctors actually miss any work. I had a little bit of sore arm. I would not have noted the sore arm just sitting here, but if I reached up above my head level, I would say, oh yeah, I got my shot yesterday. Mine lasted about 24 hours. My wife had headache for about 3 days. It went away with Tylenol. She did not have to miss any work. So we tell people you will get side effect, but it's minor compared to COVID itself. So, keep in mind that I just looked at CDC website before I signed on. 485,000 people have died from COVID. That's more than World War II, right? World War II, 405,000 people died in 5 years. So we've had more people die from COVID than World War II. So yeah, COVID is bad, and the vaccine is nothing compared to getting COVID.
Yeah, so true. That's a really excellent message. And along the lines of vaccines, there are other manufacturers that will be coming out with vaccines maybe within months or so. Each will have different efficacies, and also they were manufactured to, I guess, respond differently or to interact differently with the virus. So in the end, for us, does it matter which one we get?
No, get the one that can go in your arm. So realistically, most Americans will get Pfizer or Moderna. Okay, so there's going to be 600 million doses by July of Pfizer and Moderna. There's going to be 100 million doses of Johnson & Johnson by July. I think the FDA next meets February 25th, and that's when they'll take up Johnson & Johnson. And most likely they're going to get FDA emergency use authorization. Most likely they'll be putting out vaccine from March. And the Johnson & Johnson is a one-shot vaccine. It's 66% effective in preventing illness and 85% effective in preventing serious illness and 100% effective in preventing death. But I would imagine, I have no say in anything, but I would imagine that Johnson & Johnson, obviously it's not going to be as much. It's 100 million doses compared to 600 million of Pfizer, Moderna. If I were the guru of the world, I would give Johnson & Johnson to all the homeless people. Because you don't know if you're going to be able to catch them again. I would give Johnson & Johnson to, say, prisoners, because you don't know if they're going to be released or escaped. I would give it to people that it's hard to get to. So, for example, one of the Department of Health is struggling with all the homebound that are not in care homes. Johnson, I've made a recommendation. I don't think they'll listen to me, but I said immunize the caregivers instead. So because the people that are homebound don't go out of their home.
Right.
They're at home. Their biggest risk is the people that come in and out of the home. So I recommended that they immunize the caregivers at the current mass immunizations, wait for Johnson & Johnson, and then give the people that are homebound Johnson & Johnson, because you can just go out one time and give them a shot. You don't have to come back in 3 to 4 weeks. But I think Johnson & Johnson is going to have a definite role. But I think the vast majority of Americans will be getting either Pfizer or Moderna. Not sure when and if AstraZeneca will be presented to the FDA. And like the Johnson & Johnson, it's the DNA adenovirus vector, but that one is a 2-shot. So Johnson & Johnson right now is the only 1-shot vaccine.
Okay, then moving to another topic along the lines of what we know now that we didn't know a year ago. Can you speak about the virus, vaccines, any topics as they relate more so to the elderly, vulnerable populations with underlying illnesses? Have we refined our knowledge anymore over the past year?
No, I think in general we've kind of covered the issues. We know that most of the people who died, like 40% of the deaths, were nursing home patients. So when you look at the very vulnerable, the elderly are definitely the most vulnerable people. So we definitely need to do that. Oh, I know one question that hasn't come up that people will have: will the vaccine be required? Okay, so answer: you cannot require a vaccine that's under emergency use authorization. However, Pfizer will probably get full FDA approval. They're I think, going to go for full FDA approval in April. Now, at that point, people could require the vaccine to be, could require that people have the vaccine. It will probably be more like private companies. So hospitals, for example, could require that all their employees get vaccinated. It could be required for travel. We have the precedent of yellow fever vaccine. So if you're going to go to South America, you have to show that you had yellow fever vaccine. It could be required for colleges. So right now, if you go to college, you have to have a meningitis vaccine. They could make it that you have to have a COVID vaccine also. So it could be required in certain circumstances. And actually, it could be, I don't think any state will, but a state could require COVID vaccine. And that's already been justified by the Supreme Court. So a 1905 case of Jacobson versus Massachusetts for smallpox, the Supreme Court gave Massachusetts the right to require that Jacobson get the smallpox vaccine. So if a state wanted to require vaccination for all of its people in the state, they could do that.
Okay, and here's a question from Gary. Can you speak to the individuals with autism, cognitive deficits, etc., and being prioritized for vaccination?
Okay, being prioritized. Okay, I thought, Gary, thank goodness, I thought you were going to be talking to me about Dr. Wakefield and MMR and autism. Okay, so so that one is fake. Dr. Wakefield lost his license. It's been shown that MMR vaccine does not cause autism. But for priority for COVID vaccine, right now, we do know that people with cognitive impairment have a higher risk of getting COVID. But that's been mainly looked at the geriatric population and people with dementia. And you could see that because if they don't understand that they have to keep their mask on or they have to wash their hands, they're going to be at higher risk. To be honest, I'm not sure how it's going to roll out because that's up to the Department of Health. So the CDC has its whole list of people that are at risk for getting COVID, for example, diabetes, immune compromise, COPD. These are people that are listed by the CDC. People that are obese, have a higher risk of dying from COVID. But when it comes down to the state level, the state will actually need to decide for itself who they're going to put in the at-risk category. So for example, the state decided that healthcare workers are going to be first, and then they went to police, paramedics, fire next. They're going through the teachers. They're going through preschool teachers. So the state is rolling, even though you have this huge list of at-risk people, the state of Hawaii will decide who's next up to bat, so to speak. And that group is huge. So the seniors is 109,000 people over 75 in the state of Hawaii. The next group, the at-risk people, is 500,000. Okay, so it's 300 to 500,000. And then, so that's going to be a huge group. How do you decide who gets it at what time? The good news is that probably by April, most people, like I think Gottlieb at the FDA, estimate that the vaccine supply is going to flip, and the vaccine supply is not going to be the problem, and the problem is going to be the vaccinators, having enough people give the vaccine. So for people who are waiting, April is probably going to be when you don't have to wait anymore. And by July, every American who wants to have the vaccine should be able to get the vaccine, because we're going to have enough for 400 million people, and we have only 330 million people in the United States. And then our job is going to be to vaccinate the world, because COVID doesn't go away until we vaccinate all of the countries who don't have the resources to vaccinate their own people. So that's going to be an issue.
Okay. Oh, go ahead, Gary.
It seems like it's very important for all of us to realize that this is not an individual situation. It's a community-wide, global-wide situation. Without cooperation, it's not going to work.
Absolutely. We need 70 to 80% of the population to get vaccine. So with flu shot, Hawaii is actually not bad. We're 10th in the nation for flu shot, but that's only 50% of people in Hawaii get the flu shot. Okay, this one is, we have to do it for our community. We have to do it for our country. This is one that everybody needs to get done. Okay, if we wait for herd immunity, earlier when I first did the slides, it was only 6.7% of Americans had COVID. If we wait for herd immunity, instead of 500,000 Americans dying, it will be 2 million to 6 million Americans that will die in order to get herd immunity. If we want to open up the economy so that teachers don't get furloughed, state workers don't get furloughed, small businesses don't close, if people want to sing in church again, maybe you don't want certain people to sing in church, but if you want to sing in church again, if you want the economy if you want kids back in school so that they can, have the experience of being in person in school, everybody has to get the vaccine. You're absolutely right, Gary. You hit it on the spot.
So we don't have any more questions from the audience, but Dr. Suzuka, I was wondering, along with the message of vaccines, do you have any final takeaways for our audience? And then, of course, we will be the evangelists and spread the message to family and friends. Definitely. Yes.
Yes.
Any final takeaways for us?
Yeah. So number one, continue to social distance and wear your mask. We cannot put that away until 70 to 80% of the population is vaccinated. If this were a football game, we're in the fourth quarter of the football game, okay, and we're up 14 points. We just have to not fumble. We just have to not throw any interceptions. We just have to keep on doing what we're doing. Hawaii's doing a remarkable job. We're almost there. The finish line is in sight. But we just have to keep on doing what we're doing, and then by next year this time, in fact, by Thanksgiving or Christmas, we're going to have a much more normal world if we all keep on doing what we're doing.
All right. Well, again, thank you so much, Dr. Suzuka. And we really appreciate you spending your time with us. We we give you great encouragement and praise, and thank you for your service to our community and certainly to our caregiver support group. So thank you very much for spending your time with us this afternoon.
Okay.
Thank you,
Right.
Dr. Suzuka.